My name is Dr. Patel. I'm the Director of Head and Neck Surgery here at Mercy Hospital. I wanted to talk to you about weaning protocol for tracheostomy patients. We've all experienced weaning a patient off the ventilator in order to extubate them in a normal endotracheal intubation, but it's slightly different with tracheostomies. In the beginning, it starts off pretty much the same, where you're starting SBTs and taking them, putting them down to, pressure support and all that kind of stuff. Once we get them off the ventilator and we place them on a T-piece, that's similar. And then it changes a little bit, because these patients, for example, we change them from a T-piece to something called a blow-by or a trach collar, where you have that mask and humidified oxygen that's being delivered. And then, you get to moving them to room air, and then you start the protocol for potentially decannulating them. And so if you have the tracheostomy here, the next step is to use what's called a Passy-Muir valve. This is a one-way valve that clips basically directly onto the trach, and this allows the patient, it allows air in, but it doesn't allow the air out. And so this allows the patient to breathe, but also to speak at the same time. And so at this point, if they're able to tolerate that, where they're not able to, exhale the air, and basically what's happening is that the air comes in, goes into the lungs, but then upon exhalation, instead of passing through the trach here, it passes, remember the vocal cords are above the tracheostomy, so the air passes above the vocal cords and out, and that's why they can speak. If those patients can tolerate that, I generally like to do that for a 24-hour period. You can do less depending on how the patient's doing, but you don't necessarily want to rush the situation. This is another type of Passy-Muir valve, where it's just a different design, but same idea, that the air will go in but will not come out the trach, but it will come up through the vocal cords and through the mouth so the patient can speak. So we've gone through the two different types of Passy-Muir valves, and then you've got a cap. Now there are different types of caps. This is one that will fit directly onto the inner cannula, and that essentially caps the trach. So essentially now the patient, for all intents and purposes, does not have a tracheostomy in place. The air does not go in, the air does not go out. The reason why you're keeping the tracheostomies in place is in the event that they don't tolerate that, you want to keep it on for a certain amount of time, and so you're basically simulating decannulation for these patients. And so now the air is coming through the vocal cords, through the mouth as normal. I generally like to keep these caps on for an additional 24 hours, make sure the patient's saturating okay. You can always put them on a nasal cannula or anything else that you would do for a patient who doesn't have a tracheostomy, to give them supplemental oxygen, but that they don't necessarily need the tracheostomy. After 24 hours, once that's passed, then I will go ahead and decannulate the patient with confidence that they'll be okay. What I generally do after I decannulate them, I will place a dressing on the stoma. My preferred, and this depends on every surgeon, my preferred dressing for these is any sort of non-adherent dressing, whether it be adaptic or Vaseline gauze. I prefer Xeroform, given the antibacterial properties. So I put a small rectangular piece of Xeroform over the stoma. You want to make sure that that's not cut too small that the patient can aspirate it. So it has to be at least 1.5 times larger than the stoma, just so that there's less risk of aspiration. I put one layer of gauze. I have a little trick that I use. I put a little EKG lead, and then I put a piece of gauze on top. And then I put that whole sandwich, and then I put some Metapor tape. The reason I put that EKG lead is that the reason why the stoma is going to close eventually, but it helps to hasten the healing if the patient's able to close every time they talk or every time they cough, they're able to press on that stoma and close it. Because if you're talking and you're coughing and the air's coming out of here, then it's going to take longer for that stoma to close. The EKG lead allows them, kind of to feel, and they feel a little knob, and they'll know where to press on the stoma. It's just for the patient to be able to do that. Every time the patient coughs and speaks, just closes the stoma a little faster. And so in particular for my patients, they're a little different than the other patients that I mentioned, neurologic injuries, septic patients, patients who perhaps may not be expected to recover, things like that, where we expect to have a tracheostomy long-term, if not permanent. The vast majority of my patients are not the case. The reason why most of my patients have tracheostomies is because of the nature of the surgery that I'm doing, either the location, the extent of the surgery, that I expect them to have enough airway edema that I want to protect their airway for several days and not have them intubated during that time. Because, we could easily keep these patients intubated for that time, but then it's much harder to have a patient on a ventilator with an endotracheal tube without sedation. You can't wake them up, all that kind of stuff. Tracheostomy, if I anticipate, 3, 4, 5 days of edema, then even if they have a tracheostomy, we can get them into the chair, we can get them moving, put the Passy-Muir valve, get them speaking, things like that. Obviously, you can't do this with an endotracheal tube. So this is kind of a way that and that most head and neck surgeons will manage these patients. Well, we'll do an upfront tracheostomy. But remember, the goal for these patients, for my patients, is almost always decannulation prior to discharge. The few exceptions will be patients who have larynx cancer, for example, or a large hypopharyngeal cancer, where I'm providing a tracheostomy because not only the surgery, but also if they are getting chemoradiation to that airway, or even if they're not having surgery, they're getting primary chemoradiation. Those people are going to get very high dose radiation to the airway, and so I anticipate there's going to be issues with the airway for a longer period of time. So these patients stay trached for several weeks or months. But the vast majority are not the case, and the expectation is to decannulate these patients prior to discharge. So what I encourage the nurses to do, the respiratory therapists and the physicians in the ICU, is to be proactive about providing a weaning protocol, not once a day, but every few hours, every so often, and you'll see these patients will be able to be decannulated very quickly and certainly before discharge.